Director ma'am, respected Dean ma'am, teachers and dear colleagues. I'm Dr. Vishnu from Department of Endocrinology. Welcome you to the clinical grand rounds. So today I'm going to tell you the story of Mr. M, who is a 33-year-old male, who is a shopkeeper by profession, and he is from Moradabad of UP. And he is presented to our ED 6 months back with complaints of uncontrolled blood sugar more than 6 months, recurrent episodes of vomiting and diffuse abdominal pain, which was lasting more than 3 to 4 days. So he was apparently normal 4 days back. He developed multiple episodes of vomiting, which was non-projectile, non-bilious, but it was associated with significant retching and blood streaks towards the end. And it was associated with epigastric pain, which was diffuse vague pain with no radiation. There was no history of any precipitating event, no history suggestive of food poisoning, no history of fever, jaundice, decreased urine output, no history of headache or blooding of vision. So in past history, the patient was diagnosed with diabetes mellitus 6 years back. He was diagnosed because of osmotic symptoms including polyuria, polydipsia and weight loss, with no history of hospital admission at the time of diagnosis. And initially patient was lean phenotype. And initially he was started on desi medications, which he took for 5 to 6 months. Later he was shifted to OHA. The patient was maintained on oral drugs for 3 years without ketosis and hospital admissions. And no proper self-monitoring of blood glucose was done and maintained. Patient had poor compliance to treatment and poor glycemic control, and patient continued to have osmotic symptoms. And he is admitted with episodes of vomiting, abdominal pain and high blood sugar 3 years back, and he was found to have DKA, which was managed with IV insulin and IV fluids. And after that admission, he was discharged on basal bolus insulin at a dose of 0.7 international unit per kilogram per day. And though he was compliant to insulin, he was not compliant to diet and exercise regimens for diabetes. And he has fluctuating sugar levels since then. So in the past 3 years, patient had history of multiple admissions with vomiting and documented DKAs. Each episode starts with vomiting associated with severe retching, which was followed by abdominal pain. Initially, the admissions was once in 3 to 4 months. Later, he had monthly admissions. And vomiting and abdominal pain continues to persist even after attaining euglycemia and acidosis correction in the IP. So for the past 2 to 3 months, there is history of repeated episodes of vomiting. The repeated episodes of vomiting lost its cyclicity and cyclical pattern, and it has become more erratic and unpredictable. And patients started to present with vomiting episodes, abdominal pain, high blood sugar level in mild or no DKA. So this was the timeline of recurrent vomiting. The patient has first presented to our ED in November 2022. So the ED presentation was with severe vomiting, abdominal pain, and the patient was in severe DKA. He was managed with IV fluids, insulin infusion, and antiemetics. And vomiting persisted despite correction of hyperglycemia and acidosis. And patient had vomiting for 4 to 8 days, and he was discharged on basal bolus insulin and oral antiemetics. He again presented to us in December 2022. He was readmitted with recurrent vomiting and abdominal pain. This time there was no documented DKA. Blood sugars were optimized with insulin infusion, and later he was shifted to basal bolus therapy, and he is discharged. In January, he is admitted with recurrent vomiting. At that time, there was mild DKA, and vomiting episodes were so severe, and it was disproportional to the level of DKA. And the patients were discharged on antiemetics this time. In February 2023, the patient has presented to our ED with vomiting episodes every 15 to 20 minutes and abdominal pain. There was no history of DKA at this time, and vomiting persisted for 9 to 10 days, and it was managed with antiemetics and prokinetics. And in March and April of 2023, the patient has presented with recurrent vomiting, which was increased in frequency and duration of vomiting episodes. There is history of 2 to 3 admissions with similar complaints. There is no history of DKA. And the patient had one episode of hypoglycemic seizure in IP in April, which was treated with IV dextrose. And there is history of readmission within 2 days after discharge with similar complaints, that is recurrent vomiting. There is no history of precipitating events, or there is no history of stoppage of insulin. No history of early satiety or stomach fullness. No history of decreased appetite, postural dizziness, and nausea in between the cyclical episodes. No history of weight gain, cold intolerance, or dry skin. No history suggestive of eating disorders. No history of fever or night sweats. No history of diarrhea or steatorrhea. So the patient used to self-administer insulin. So he used to take 0.7 to 0.9 international unit per kilogram per day of insulin. and the methods of administration and storage were proper. And he used to self-monitor the blood glucose 3 to 4 times a day. And most of the SMPG readings are in between 100 to 200 milligram percentage. Occasionally it exceeds 300 milligram percentage. And there is symptomatic hypoglycemic episode which is more related to skipping of food and which were improperly managed by the patient. So there is a history of seizure 6 months back while he is traveling in a bus, which was associated with abnormal movements and loss of consciousness. And he suffered right humerus fracture. So there is no history of documented hypoglycemia during that episode. Then he also had history of burning sensation in bilateral feet, but there is no history of decreased sensation or slippage of chapels. No history of decreased vision or frothy urine. No history of coronary artery disease, cerebrovascular accident or peripheral arterial disease. And patient was diagnosed with HCV reactivity in January 2021 and he was treated with direct antivirals for 3 months. So the infection was resolved following the treatment. So regarding his family history, he is a 33-year-old male who is married for 8 years and he is having 3 children and he is staying with his mother away from his wife because of personal reasons. There is history of adult onset diabetes in his paternal uncle. There is no history of thyroid disease, migraine, and mother had denied history of abnormal behavior and any triggers for vomiting episodes in all previous admissions. And mother is taking care of him and she maintains a log for vomiting spells and she maintains a sugar chart for him. So regarding personal and social history, he is a reformed alcoholic 3 years back. He was taking non-cirrhotic range of alcohol before that. So he's a reformed smoker and there is no history of substance abuse. And he consumes mixed veg predominant diet and his sleep and appetite was normal. And social history, he belongs to a lower middle class family and he is steady till 9th standard and he is a dropout due to financial issues in the family. So he is a shopkeeper by profession. Currently he is not working since 2 months because of these recurrent vomiting episodes. So summarizing the history, we have a 33-year-old married male with history of resolved HCV infection who has history of diabetes mellitus for 6 years with an age of onset of 27 years. Initially he was managed with OHAs and now he is maintained on basal bolus insulin for the past 3 years. And he has presented with recurrent episodic vomiting of erratic pattern. Initially which was cyclical, later the vomiting has lost its cyclicity and has become erratic and unpredictable. And he had a history of abdominal pain with each episode associated with hyperglycemia and occasional DKA. So patient was treated from our ED and from our side with IV fluid and IV insulin and diabetics during each episode. So the differential diagnosis, we have a 33-year-old male patient who has had history of diabetes from 27 years of age. He was lean, it was an early onset diabetes and lean to start with, lean phenotype to start with. So there is no history of obesity or any insulin resistance and there is feature suggestive of absolute insulin deficiency. So our thought process was, we had 2 diagnoses, one is type 1 diabetes and other one is a hybrid diabetes, that is LADA, latent autoimmune diabetes of adults. So LADA is otherwise known as 1.5 diabetes because it has the feature of both type 1 as well as type 2 diabetes. So usually LADA is according to ADA 2023 classification, there is no place for hybrid diabetes and LADA comes under type 1 diabetes only. So LADA is characterized by progressive loss of beta cell function. So it will present in later ages, that is after 30 years, and there will be history of insulin independence for more than 6 months. So type 1 diabetes can present in childhood and the initial presentation can be DKS, unlike in this case. So the features are more likely suggestive of LADA than type 1 diabetes. So along with that, as the course
behind the picture?
With ma'am, with diabetes with ma'am, type 1 diabetes with. So with
LADA versus type 1 diabetes
with. So the cause of intractable and recurrent vomiting, the causes we considered were TKA, adrenal insufficiency, diabetic gastroparesis, chronic infections like abdominal TB, and cyclical vomiting syndrome.
Yes.
Anyone wants to, students, anyone wants to come and discuss the differentials?
No.
Please, in the frequency, the first probable diagnosis, second, third, or it is random? Like you written DK, because in this case, the DK is not the diagnosis.
No, it isn't random.
Is it in that order or it is random?
It is random order.
It should have been like,
No.
in the sense that what you thought was the first and the second. So what is the first and second?
We actually got the order based on the commonness of the diagnosis.
No, but
Oh.
you have the course in the hospital and DK was not there for
No.
all the pre-admissions.
So I'm discussing the possibility of diabetic ketoacidosis. As you all know, diabetic.
Repeating the question. 1, 2, 3, what are your first three differentials?
So my first would be cyclical vomiting syndrome, because there were symptom-free episodes where in between the vomiting episodes where the patient doesn't have vomiting as well as nausea. So even after the resolution of diabetic ketoacidosis also, the patient was having persistent vomiting, and as which is followed by possibility of adrenal insufficiency. It could be a case of autoimmune diabetes. So autoimmunity can affect adrenal glands also. So there can be primary adrenal insufficiency which can present with nausea and vomiting. But still the cyclical pattern is not explainable by adrenal insufficiency. Then diabetic gastroparesis, the patients will have full-on symptoms throughout the course. So this patient was not having symptoms suggestive of fullness as well as early satiety. And symptom-free interval was prominent. So in between the episodes of vomiting, the patient was totally symptom-free and he was tolerating all types of feeds. So it will these diagnoses will come down. And DK is practically not possible, even though type 1 diabetes or autoimmune diabetes in the later stages can present with DK. But even after the resolution of acidosis, as well as even after attaining euglycemia, in this case, the patient had recurrent vomiting. So probably cyclical vomiting would come up in the guns. No, it cannot be. The patient can have symptoms throughout, but still as it is.
So other differentials which I would consider in this patient with history of pain, abdomen, recurrent vomitings, and one past history of seizures, one would be a possibility of porphyria. Acute intermittent porphyria can have similar presentation. And second possibility will be a psychiatric disorder like factitious disorder. So if some of you are interested, recently in a NEGM, there is a case records of Massachusetts General Hospital. They had a case of acute intermittent porphyria with recurrent vomitings not controlled with hemin. If you can go across that. And third will be fatty acid oxidation defects, but possibly the age of the patient is probably, it happens more in pediatric populations as associated with rhabdomyolysis. So cyclical vomiting syndrome, your last two episodes, the duration was less than a week. So according to the diagnostic criteria of cyclical vomiting syndrome, as far as I remember, you should have a symptom-free period of maybe weeks, maybe more than a week, to label it as cyclical vomiting.
Why can't it be recurrent acute pancreatitis? Pain, abdomen, vomiting.
The patient never had any symptoms suggestive of exocrine pancreatic insufficiency also. So, and in between, actually the pain-free periods were like months initially. So, which is also.
Was the pain ever suggestive of pancreatitis?
No, it was a diffuse vague pain rather than.
Diffuse vague kind of pain.
So, regarding the option of diabetic ketoacidosis, diabetic ketoacidosis can very well present with gastrointestinal symptoms of vomiting, abdominal pain, and high blood glucose, and can occur with insulin-dependent diabetes. But the facts which were against the diagnosis of DKA include not all episodes were associated with DKA and persistence of vomiting despite attaining euglycemia and euacidemia. So episodic vomiting was disproportionate to the degree of DKA, especially when the patient had presented with mild DKA the patient had intractable vomiting in that episode also. So adrenal insufficiency can present with history of nausea, vomiting. There is history of weight loss in our patient, but there is no history of any salt craving, no history of any postural dizziness or postural hypertension in our patient, no nausea in between the cyclical episodes of admission. Then regarding diabetic gastroviruses, there is poorly controlled diabetes for past 6 years. And the factors which are against the diagnosis of diabetic gastroviruses includes intermittent episodes and no history of early satiety and fullness, intermittent complete well-being even without treatment, and tolerability to all kinds of foods in between the episodes. So regarding chronic, we consider the possibility of chronic abdominal infections like tuberculosis also. So the points which were for the diagnosis of abdominal infections include history of chronic course of disease with nausea and vomiting, history of diffuse abdominal pain, history of weight loss, and but the patient never had any history of fever or night sweats. So coming to the examination, when we received the patient was not having any evidence of dehydration. Glasgow Coma scale was 15/15, and BP was 120/72 millimeters of mercury in sitting and 124/70 millimeters of mercury on standing. There is no postural hypertension. Pulse rate was 94 per minute, and height was 159 centimeters, and weight was 50 kilograms, and BMI was 20.5 kilogram per meter square. And sexual menstruation rate was adrenarche present, and testicular volume was 20 ml bilaterally, and stretched penile length was 13.5 centimeter. So the patient had no evidence of hypogonadism. CVS examination and respiratory system examination was within normal limit. GAT examination, there was no distension, the abdomen was non-tender on palpation, no hepatosplenomegaly, normal bowel sounds are heard. And CNS examination, fundus examination, there is no diabetic retinopathy. Bilateral monofilament examination 10/10 on both feet. Bilateral pain, touch and temperature was within normal limits, and bilateral vibration and proprioception was within normal limit. So coming to the investigations, the HB of the patient was 10.2, so patient had mild anemia, and platelet count was 1.25, so the patient had thrombocytopenia. And urea, creatinine, sodium, potassium values were normal, and LFT was normal except for low albumin. The albumin level was 2.6, and lipid profile was also normal. And TSH was 3.6, free T4 was 1.05. The patient is euthyroid, and viral markers were positive for hepatitis C infection, but viral load was not detectable. And vitamin D was in vitamin D insufficient range, that is 17.98 nanogram per ml, and calcium and phosphorus was 8.8 and 2.5 respectively. So 24-hour urine protein was 132 milligram per 24 hours, and peripheral smear examination showed normocytic normochromic anemia. Then HbA1c was 8.2%, which indicates poorly controlled diabetes. Lipase and amylase were negative, and stimulated C peptide was severely suppressed. It was less than 0.05 nanogram per ml, and anti-GAD antibody was significantly elevated. It was more than 2,500 units per ml. And fecal elastase was also low, 62.5 microgram per gram. And LH and FSH was normal. 8-time cortisol was 17.1 microgram per deciliter. And post-ACT stimulation, it has risen to 33 microgram per deciliter, which was normal. So autonomic function test was showing minimal parasympathetic involvement. So after this investigation, the possibility of decay is ruled out based on history, and adrenal insufficiency is ruled out based on 8-time cortisol levels. So still we were suspecting diabetic gastroviruses, chronic infections, and cyclical vomiting syndrome. So the second tier of investigations included gastric scintigraphy, which showed a more than 96% gastric emptying at 4 hours, which was normal. So gastroviruses is practically ruled out, and MRI brain was done to rule out any central causes for vomiting, so which was also normal. And USG whole abdomen was done, which was normal. And upper GA endoscopy was done, and which showed grade D esophagitis. And CCT abdomen showed ileocecal valve thickening and atrophied pancreas. So because of the ileocecal valve thickening, ileal biopsy and CB-NAT is done, which was non-contributory. And Mando test was negative for the patient, and IgA TTG as done as a part of autoimmune worker profile, which was also turned negative. It can occur in autoimmune diabetes also. It can occur in chronic pancreatitis. So, after the second layer of investigations, the possibility of decay, adrenal insufficiency, diabetic gastroparesis, chronic infections like abdominal TB were ruled out, and we were left with cyclical vomiting syndrome. So, regarding cyclical vomiting syndrome, so the patient who have intermittent episodes, as a patient had, and intermittent complete well-being even without medication. But according to Rome 5 criteria of cyclical vomiting syndrome, there should be at least 2 acute onset episodes in the past 6 months, but each episode occurring at least 1 week apart, persisting less than 1 week. But for our patient, patient's episodes were actually, the frequency of vomiting episodes were increasing over time, and the duration of each episode was exceeding 1 week towards the last. And absence of nausea and vomiting in between the episodes, which are also a finding for our diagnosis for our patient. So, no supportive findings include personal or family history of migraine was reported in our patient, and the pattern of vomiting has turned erratic and unpredictable towards the end, unlike cyclical vomiting syndrome. So, in the current admission, the patient was showing excessive irritability and anxiety and decreased sleep. The vomiting episodes lost its cyclical pattern over 2 to 3 months, and organic causes are ruled out. So, twice in the last 2 discharges, the patient was overly anxious about discharge and got readmitted with vomiting on the same day itself. Hence, psychiatry evaluation was sought. The patient is currently evaluated under psychiatry. So, the psychiatry part will be discussed by Dr. Vasundhara from psychiatry.
So before that, at this point, some rarer diagnosis, like sir mentioned, was considered, such as abdominal migraine. But again, there was no family history of migraine or personal history of migraine, and in fact, in one of the admissions, before he lost his cyclicity, we had even treated him with sumatriptan, but there was no effect on that. And later, AIP was considered, but usually AIP has more than 80% patients have hyponatremia sometime at any time in the point, which this patient did not have. And usually CNS manifestations, neuropsychiatric manifestations should be obvious, which was not obvious to us at that point in time. But we did consider evaluating for AIP as well. And other rarer things that we considered were, so our working diagnosis for a long time was cyclical vomiting until he lost his cyclicity in the last 2 parts. And even in the meantime, patient had denied all kinds of, even the mother had denied any abnormal behavior at home or any kinds of triggering factors. They were maintaining a log, but there was no triggering factor for vomiting that we were trying to look at. But towards the end, because the moment we say we want to discharge, the patient would feel very anxious and get readmitted. So that's when we thought, let's have a psychiatric review. And we presented.
Before we, psychiatric evaluation of course will be needed when the patient is overtly anxious and there is anxiety, but I think somebody who's been having recurrent pain of this type and vomiting would certainly be predisposed to, getting anxious because of various things.
Actually, that is what we thought. That he was just anxious about being repeatedly being admitted.
Yeah. So that is one possibility, but secondly, I think possibility of chronic pancreatitis is still there. We have seen cases in which patients get abdominal pain and vomiting, and this pain may not be very, very severe as is seen in acute pancreatitis. So these patients have associated, like their mutations are like cystic fibrosis mutations, and they also get diabetes. Like this patient also has diabetes and he has atrophied pancreas. On the ultrasound, I wonder if CT was done to actually find out if there is any associated features of chronic pancreatitis and other investigations for chronic pancreatitis, because all that will anyway give rise to pain, and pain will be responsible for anxiety.
And CT was done, and it showed atrophied pancreas, which is a common finding in.
Can we see the CT? Because it was a very distinct pattern of calcification.
There was no calcification reported. We have not included the CT. It showed atrophied pancreas, which is a common finding in type 1 diabetes. There also pancreas is atrophied. So we thought we looked at the exocrine insufficiency, which will commonly be present, which was not there. Fecal elastase was.
What was the C-peptide?
C-peptide was low one, and that is positive. This is type 1, but because it is later onset, it would be LADA. Yes, ma'am. The one that happened in hospital was associated with hypoglycemia. One had happened before. He did not document any hypoglycemia. Ma'am.
Recurrent episodes of abdominal pain. We've also seen that it could be because of abdominal angina, because of AV malformations and so, which is picked up by actually contrast angio, may not be picked up by regular CT. So we have got cases like that. I think 2 cases we reported. Patient frequently came with abdominal pain and that kind of symptoms. His patient was otherwise ultrasound wise, everything used to be normal. I think that also has to be ruled out.
Good morning, everyone. From here onwards, I'll continue the psychiatry part. Patient was first seen by psychiatry on-call team in March 23 when patient was admitted in endo ward for unexplained vomiting episodes. He was provisionally diagnosed with cyclical vomiting and was started on tablet amitriptyline 10 mg at night. Patient was reviewed during readmission in April and was transferred to psychiatry ward for further management and observation after he was being medically stable. In the past 3 years, following behavioral changes were seen. There was irritability which persisted throughout and it increased during the vomiting episodes. He used to be verbally and physically abusive towards his family members. He was less cheerful and there was less interaction with family members. Sleep disturbances were there and lack of joy in his day-to-day activities during the episodes and also without the episodes was present. Ghabrahat was present for 3 years, which was initially once or twice a month, associated with palpitations, shortness of breath, abdominal discomfort, sweating, shivering of hands, which lasted for 30 to 60 minutes. And it was present during both hypo and hyperglycemia phase and sometimes during symptom-free intervals. There was belief that was held by the patient. He said that he felt a sense of control and referred to it as dabav, which was almost continuous, involuntary, causing pain and discomfort in abdomen and ultimately led to uncontrolled vomiting episodes. Further, patient attributes this dabav as the main reason for his irritability and limited social interaction. Multiple trance and possession episodes has been reported post-marriage in which he would claim himself to be the man who was killed by his father and would blame his mother for infidelity. Despite giving all the contrary evidences by the mother, he held those beliefs and remained irritable towards her. Psychosocial issues were also present. There were multiple interpersonal relationship issues with wife and family members. It was followed by 2 self-harm attempts. One was there in 2022 and one was following distress from the illness. There were financial stressors as well, as he was the only earning member. Debts and multiple hospital admissions were there. In the negative history, we tried to rule out persistent, pervasive low mood, elated mood, grandiosity. There was no history suggestive of binging or purging. No history suggestive of body image distortions or weight concerns was there. No history suggestive of any delusions of persecution, reference. No history suggestive of hearing of voices not heard by others or disorganized behavior, disinhibited behavior. And no history suggestive of any obsessive nature of any thought or activity. And there was also no history suggestive of psychoactive substance use. Family history was positive in father for schizophrenia, and there was also psychiatric illness reported in paternal uncle and paternal aunt. There is history of suicide in elder sister. In the mental status examination, the only positive finding that we found during the course of admission was overvalued ideas in the thought content. During ward course and treatment, the patient was closely observed by the treating team for behavioral assessment. He was given ABC checklist that we do for cognitive behavioral therapy, and he was asked to fill it just before he started experiencing anxiety symptoms or worrisome thoughts in the pre-emetic phase. Initially, there was non-adherence by the patient, which posed as a difficulty for us. Staff was instructed to record autonomic symptoms when patient reported anxiety symptoms. And based on that, he was started on tablet sertraline 50 milligram and tablet clonazepam 0.25 milligram thrice a day. There was a reported improvement in irritability, anxiety symptoms, which he attributed to as dabao, and there was considerable improvement in social interaction was there. No vomiting episode has been reported since last 15 days, though patient is still under observation. Our differentials includes the vomiting which cannot be explained by any physical explanation. First one goes as somatoform autonomic dysfunction with upper gastrointestinal symptoms. There was there is preoccupation with severity of bodily symptoms and excessive attention despite counter explanations. Also, there are repeated healthcare contacts and market distress is there. Second, it can be explained by any psychotic disorder, for say patient is hallucinating or there is delusion regarding the vomiting episode. And the third one goes at dissociative disorder, where there is disruption or discontinuity in identity, sensations, perception, affects, thoughts, memories, control over bodily movements and behavior. Thank you, everyone.
Thank you. Now, Vishnu will summarize the final diagnosis and
So the final diagnosis is young onset diabetes, that is LADA, latent autoimmune diabetes in adults, and the recurrent vomiting was associated with dissociative disorder and somatoform autonomic dysfunction, and the patient had treated hepatitis C infection. So the take-home message was psychiatric conditions can present with entirely somatic symptoms. So social stigma may make getting a relevant psychiatric history not very forthcoming. So it's important to analyze the symptom pattern and evolution to consider non-organic causes. So long-term patient follow-up is the key to diagnose such conditions. Thank you.